Welcome to KSSK CMD Chats.
Hi, I'm Kierra.
Hi, I'm Sophie.
Today is actually going to be an exciting episode because we're talking all about breathing. I've actually talked to my pulmonologist and orthopedic doctor a lot about breathing and my scoliosis. Wait, didn't you actually have a surgery for your scoliosis last summer?
I did, not last summer, it was a few summers ago. I went down to San Diego. I got spinal fusion, which is basically they put a two titanium rods in my spine so that it would they cut into me, baby. It sounds scary, but really it wasn't that bad. And they were made of titanium, so now I can sing that Sia song, No Lies.
How did you feel any different in terms of your breathing when you woke up?
I don't know about that because, I was still kind of, I was still on pain meds, you know?
Oh.
Right. So, one thing I distinctly remember was having, tubes down my throat. It's because, they want to keep you, breathing while you're under anesthesia, you know, so. But I know now that I sit up straighter and I have better posture because of it. And if I hadn't had that surgery, I would have much worse posture now. And that would have impacted my breathing.
I'm excited to learn about breathing actually today in the episode. Do you know who we're going to be talking with today?
Yes, we are going to be talking with Dr. Sawnani and Dr. Mayer. They're going to talk to us about an overview of breathing, basically. Yeah.
That's going to be helpful. And we will head straight into the interviews.
Hi guys, we really appreciate your time today to give us an overview of respiratory natural history, or in other words, what is to be expected in terms of breathing function in someone with CMD. Could you please introduce yourselves to our audience?
My name is Hank Meyer. I'm a pediatric pulmonologist from the Children's Hospital of Philadelphia.
I'm Hemant Sawnani. I'm also a pediatric pulmonologist at Cincinnati Children's.
Can you help explain to us why and how CMD affects breathing and possibly causes breathing complications?
When you have weakness with progressive stiffening of the chest, it would be similar to asking someone who has a band across the chest to run up a flight of steps. So the combination of a weaker diaphragm means a shallower breath. Tighter chest wall also means a shallower breath. And weaker abdominal muscles, which actually come into play when you want to expel secretions, also leads to an ineffective cough. So as it stands, an individual can actually lose almost 60 or 70% of lung function over many years and still maintain a conversation with you in a wheelchair. But the moment we need to tap into that reserve, whether it's a fever or any stressful event, surgery, infection, then it becomes a little more challenging to take deeper breaths, and people have to resort to taking shallower and faster breaths. The other element of this is when there is weakness and someone has to lay down, it becomes harder to breathe more effectively when they lay down. And that's how they'll end up requiring a little bit of assistance with a ventilator when they sleep.
That makes sense.
Yeah.
I've heard that there are 3 overlapping phases that are the main causes of respiratory decline. Would you mind explaining those 3 phases?
Respiratory decline, respiratory difficulty starts with muscle weakness. And so that's the first phase of decline. You have a muscle, whether it's the diaphragm, the chest wall muscles, or a combination of the two that are weak. And then what happens is that it's harder to both take a deep breath in and then also breathe out as far as you possibly can. One of the things that you do when you cough is you obviously have to take a deep breath in and then breathe out as hard as you possibly can. And so when that becomes more of a challenge, then the lung capacity becomes smaller, okay? And when the lung capacity becomes smaller, the airways become a little smaller, and when you get sick, it's more likely that the airways get plugged with mucus. And then when the airways are small and the lungs are small, they become harder to move when you breathe in. So what that means is that you have to work harder to breathe in and get the oxygen you need and remove the carbon dioxide that your body produces. When that work becomes too great, that work to take a breath in, then you can get into a situation of having respiratory insufficiency or respiratory failure, which is where you need mechanical ventilation, either nighttime ventilation, which we call bilevel positive airway pressure, or non-invasive nasal ventilation. And if it progresses further during the day, patients may need daytime ventilation, either by a mouthpiece, or some people call SIP or sip and puff ventilation, or some patients decide that they would prefer to have just continuous ventilation that does not require having an interface on the face, and instead have a tracheostomy tube.
How is your muscle strength and your lung capacity and your ventilation, which is getting rid of the carbon dioxide, how is all of that related when it comes to CMD? How is it connected?
So as your muscles become weak and you breathe less deeply, most of the time during the day, you can do just fine. You can sit in a position that makes it easier to breathe. You might sit up straight as opposed to leaning over or leaning to the side. But then when you lie down, that in and of itself makes your lung capacity a little lower. And then when you go into deep sleep, one of the things that is so good about deep sleep is that all of your muscles relax. And if your muscles relax too much, and you have slightly weak muscles to begin with, what may happen when you go into deep dream sleep, which is the sleep that allows us to rest as much as possible, you may not breathe as deeply as you need to get oxygen in and then remove carbon dioxide. And so that progression happens slowly over time, but you need to be very aware of that possibility. And what may happen is that you see your pulmonologist or your neurologist, and they may express some concern about things that you're telling them about how well you're sleeping, or perhaps how poorly you're staying awake during the day, which is another thing that we look at. And if there's concern, then we may ask you to come to the hospital to do a sleep study in the sleep lab, where we can measure your ability to breathe in effectively at night.
That's really good to know. What is the connection between posture and breathing?
So let's say your diaphragm is what moves up and down in order to give you optimal breathing. So what happens with scoliosis is not just that they turn, that they just slide over to one side. The vertebral bodies actually rotate. And so that causes the ribs to turn, so the shape of the chest gets a little taut. And then this diaphragm, which used to sit like a healthy leaf, also gets taut, which makes it harder for it to move. So that could be one way by which, extreme changes in position can also affect the ability to take a deep breath. The other element of this is what happens in between the ribs. And usually whenever there are changes in posture like that, related to changes in curvature of the spine, the spaces between the ribs on one side get stretched open and the other side get narrowed out. And so both sides begin to also become a little dysfunctional in that regard. And that's what makes breathing also less effective.
Oh.
And that also affects the ability to cough.
Yeah.
So there's a domino effect that we see when the spine curvature changes.
When you have a curve to the spine, or you tip in one direction, either to the side or forward, what that does is that presses on your lungs to make them smaller. And we also don't think about it as it presses on your belly. And what happens there is that it makes it harder. If you're bent over, it makes it harder for your diaphragm to go down. You can get a sense of that if you tip over and touch your toes and then try and take a breath, as opposed to sit up nice and straight. Or even if he was mentioning twisting, if you turn to the side, turn 90 degrees, and then try and take a deep breath, that's harder because that's twisting the diaphragm and putting it in a position that makes it harder for it to contract effectively. And so the further you get away from having a nice upright posture, the harder it is for the diaphragm to contract.
How can we slow the progression of everything down?
Dr. Sawnani and I, a number of years ago, with support from Cure CMD, started a project to look at doing breathing exercises, sort of like doing physical therapy, but for breathing. And what it essentially involves, it's called Hyperinflation Therapy, and it helps you to take a deeper than normal breath in a couple of times a day in a series of treatments. And the idea behind that is to stretch your breathing muscles and stretch the joints of your respiratory system, which are essentially where your ribs touch your spine. If you do breathing exercises to help you breathe in more deeply and start that fairly early, then we have shown that that can change how rapidly you lose lung capacity.
With the appropriate amount of respiratory support, it's rare for our patients to ever need hospitalizations. It's largely because of the combinations of nighttime support and daytime support, whether it's in the form of cough assist or SIP ventilation. So they tend to do fairly well, and it's possible to do well.
How can an inhaler also help with breathing besides a machine or BiPAP?
The simple answer is that you use a medicine to treat something that's not working well. An inhaler like albuterol is used for patients who have asthma, and that helps to make the airways get bigger. I will admit that we're very liberal in using albuterol, meaning that we use albuterol in a lot of patients who may not necessarily need it. Sometimes what we'll do is we'll use it not necessarily because we think that you have asthma, but that we tried it once and you said, boy, you know what, that actually makes me feel a little better. And so I think an inhaler with albuterol can be very helpful. The other thing that we'll sometimes do is if we really think that you have asthma, we'll use something called an inhaled steroid. And that can be helpful in trying to prevent the breathing problems you have with asthma from happening in the first place. However, using that requires the pediatrician or the pulmonologist or the allergist to be very certain that you have asthma. If you don't, then it has no real use at all.
That's so good to know, because I was like, why did he just give me a random inhaler? But, I didn't really know that.
Well, you know what? You are very good at asking questions. And the next time you see your doctor, ask him that question or her that question.
Okay, I will. I'll be sure to.
While we're in the midst of a global pandemic, masks are currently required in public spaces. So for people like Kierra and I with CMD, wearing masks makes it hard to breathe. What do you advise as doctors?
It's just one more form of one hurdle that the bug has to overcome to get to you. The other thing is that it's a constant reminder not to touch your face. And if anything, that's the bigger benefit, I think, that comes from wearing a mask, is that really it's a deterrent or a constant reminder not to lift your hands to touch your nose. There are certain masks that are certainly more comfortable than others, and I think it's important to find that. Find the one that fits you more comfortably, because if you are prone to having to readjust it repeatedly, you are bringing your hands to your face.
Yeah.
I think the little bit of discomfort that we get from a little bit of warmth behind it is a small price to pay for the difficulty you could experience if you get sick.
Yeah, that is true.
Masks suck, but COVID sucks more.
Yeah.
So My recommendation is to make it a style statement and find one that looks nice to you, that fits well, and get used to wearing it. Let's say you're in school and or out in public somewhere, and you've been wearing your mask straight for an hour and it's uncomfortable. Take a moment and go away from everybody, go in the corner, sanitize your hands, and then take your mask off. You can itch your nose, you could scratch your cheek, and then put your mask back on and then go about your business. It's okay to take breaks. But it's critically important that if you're out in public and around other people, outside of your family, that you wear a mask.
I'm very comforted by the fact that we are able to take breaks, but I do appreciate you helping tell us to suck it up.
Well, one of the other things that I will recommend is there's a way of breathing that you can do that makes having a blockage or an obstruction easier to overcome. And that's by breathing slow and deep as opposed to fast and shallow. So what I would recommend is if you get into a feeling of, I hate this darn mask, I want it off, the doctors say I can't take it off, close your eyes for 3 seconds and take 3 slow, deep breaths. And then press restart and move on.
That's actually kind of helpful. So Dr. Mayer and Dr. Sawnani, thank you so much for being here.
You're welcome.
Thank you for having us.
Yes, stay well, stay happy and healthy.
You too.
For more ways to stay connected, download the CMD mobile app and sign up for the newsletter. Here is a link to the CMD Pulmonary Guide, which is very interesting. And if you have questions, email us at breathe@curecmd.org. And wait, before you go, be sure to like and subscribe. Add your comments below to keep the conversation going. Thanks again for watching. Bye!